Yeah. Yes. Hello. Good evening and a very warm welcome from CCI once again with a very interesting and a really out of the box kind of a topic today, which we are going to discuss. And we all discuss sleep apnea, obstructive sleep apnea in a big way. Pulmonologists do encounter sleep apnea in a very big way in their practices, and they need to know very much about that. And of course, the golden answer for majority of these patients, apart from very early weight reduction and then occasional surgery, but the gold standard answer which pulmonologists give, and we will come to that discussion eventually, is going to be CPAP, continuous positive airway pressure. Now, this continuous positive airway pressure is though gold standard. Even the worldwide experience is only 50% of the people who are prescribed a CPAP can use a CPAP, can tolerate a CPAP, and can indefinitely benefit from it. So today we are sort of going beyond the CPAP and trying to explore what else if the person is totally CPAP intolerant or is not benefiting for CPAP for one reason or the other, and how can we get that person back onto CPAP if possible. That would be still the best thing if it is only a matter of intolerance, or the other way around, can we get some additional, do we have something in our armamentarium which can help such a patient. Now, there are some things which are theoretical and advancing gradually, and there are some things which we can practically use in our daily practices. So, to help me with this very difficult topic, I would say, we have two experts. And I think Dr. Gauri Shankar, if he is not there, then I think we'll start with Dr. Pearlcid's lecture first. So I'm introducing the first speaker, and after that, you will play Dr. Gauri Shankar's recording. So the first talk is from Dr. Pearlcid Siroraj. He is a BDS, MDS, MDFR, CSI, FFDR, CSI, of course, an expert dental surgeon. He is Assistant Professor, Department of Oral and Maxillofacial Surgery, Sri Ramchandra Institute of Higher Education and Research, Chennai. He is a Director of Marvel Dentistry, Kilpok Consultant, Oral and Maxillofacial Surgeon, Chennai. So I request him to start with the talk. The rest of the faculty I will introduce at the end of the first two talks. So the first talk is by Dr. Pearlcid, and the second will be by Dr. Gauri Shankar.
Good evening, everyone. I'm Dr. Pearlcid Siroraj. I'm an assistant professor from the Department of Oral and Maxillofacial Surgery from Sri Ramachandra Institute. So I would like to thank you all for giving me this opportunity today. And I'm here to talk about the role of surgery as an osseous surgery in obstructive sleep apnea. So, I mean, we would have already discussed about all these things. So it's basically what do we mean by OSA is an increased nocturnal airflow resistance, resulting in repetitive episodes of pharyngeal collapse during sleep. So basically episodes of apnea. So what is the prevalence of it? So if we can notice, almost 76 to 85% patients with atrial fibrillation have obstructive sleep apnea. And also patients with diabetes are increasingly prone for obstructive sleep apnea. Patients with stroke, they have had histories of obstructive sleep apnea. Bariatric surgery patients, obviously they'll be overweight, and obesity, one of the leading causes for obstructive sleep apnea. So basically, what is the pathogenesis? To keep things simple, the collapse of the airway. So it can be either because of micrognathia, meaning smaller jaws, or posteriorly placed jaws, which is retrognathia, and sometimes even very subtle radiographic findings like an inferiorly positioned hyoid bone or a shortened mandibular length or a maxillary length. So all these can cause a reduced volume. Even a very small discrepancy can precipitate an episode of obstructive sleep apnea. Right, and this is one common condition that we as maxillofacial surgeons come across quite often. So, which is temporomandibular joint ankylosis. Ankylosis itself means fusion between two joints. So the mandibular bone is fused with the temporal bone. So, and that causes, in a kid, especially it's common in kids. So there is deficiency of growth of the mandible. So as you can see in this radiograph, you can see the posteriorly placed mandible. So there is going to be no movement of the mandible and there is no growth of the mandible. So it's going to be literally a closed mouth for the patient and there is going to be collapsed airway. So this is a beautiful review article which was published by Professor George Dimitrelli. So he's a famous maxillofacial surgeon. So he also noticed that concomitant sleep bruxism in patients with obstructive sleep apnea. So moving on to the indication. So when do we go? We don't really directly jump into surgery. So when do we really go for surgery in obstructive sleep apnea patients? So when the apnea hypopnea index is more than 20 events per hour of sleep, when the medical managements have all failed, when there is an obvious anatomical discrepancy. So when, let's say, a patient with TMJ ankylosing, in that patient, we are not going to go and try CPAP, so or any splint therapy, so which is of literally no use in that patient. So we need to go in for surgery when that is the only option, and failure to tolerate CPAP or CPAP is not effective, and when there is a persistent fall in oxygen saturation of less than 85%, and associated cardiac arrhythmias which are seen with the obstruction. So basically, so why do we do this surgery? To eliminate the airway collapse or reduce the airway resistance during sleep without causing an impairment to the normal functions of the airway. So these are the various surgical procedures that we have. So tracheostomy, yes, it has got its own morbidities. So we do have bariatric surgeries to reduce the weight of overweight patients, nasal procedures when we have to correct some deformity with the the nasal architecture, palatal procedures which are commonly performed by our ENT colleagues, the nasal procedures again by the ENT colleagues, tongue procedures and skeletal procedures. So I'll be talking briefly about tongue procedures and mostly about the skeletal procedures. So again, so briefly, a problem with the nose, you can go in for rhinoplasty, nasal cavity, terminoplasty, septoplasty, and polypectomy. And we have a wide arsenal of procedures for each separate subsite. So tongue-based procedures. So when do we address the tongue or when do we perform surgery on the tongue? So there is a common condition called as macroglossia. So when there is a really huge tongue which can potentially block the airway. So in that cases, yes. So significant symptoms include habitual snoring, excessive daytime somnolence, and apnea, hypopnea incidence of greater than 5, and failure or refusal to attempts at conservative treatments, and like including appliances which will try and position the jaw much anteriorly, and Friedman tongue position of 3 or 4, retrolingual or hypopharyngeal obstructions. So basically, what do we do in tongue position? So it's basically a strip of the posterior tongue in the midline is removed. So you can see the incision. And we just advance and close it. A wedge of tissue is kind of removed so that we reduce the tissue bulkiness of the tongue. So a macroglossia or a huge tongue is kind of reduced to a size that kind of fits into the mandible so that there is no obstruction of the airway. So again, another one is the radiofrequency ablation of the tongue base. So instead of cutting off the tongue entirely, and you can just cause some amount of necrosis and scar contraction, as you can see in this image. So it kind of facilitates or increases the airway because of the shrinkage of the size. So now moving on to skeletal surgery. So again, in skeletal surgery, we have wide an array or an arsenal of procedures. So one is expansion of the maxilla and mandible. So basically to expand, we need an active growth. So it can be done in kids and young adults where the fusion has not happened yet and the sutures are still intact. So we can cause expansion of the bones. And we can also do genial tubercular advancements. I'll be talking about that again. So mandibular advancement to get, so mandible itself because of the attachment of the genioglossus muscle is also there. So the entire thing is moved in front. So there is opening up of the airway. And maxillomandibular advancement with or without genioplasty, hyoid suspension, mid-phase advancement. And again, talk briefly about how to manage a patient with TMJ ankylosis. So first thing is going to be maxillomandibular expansion. So widening of the upper and lower jaws enlarge the nasal and the retropalatal airway and stiffens the soft palate. So it is usually indicated in non-obese, non-syndromic children or young adults requiring orthodontic treatment. So as you can see, what we normally do is imagine there is a suture here. So we just place tooth-bone appliances here and we'll have to activate the appliance. So it's just like distraction osteogenesis over here again. So we just place a cut maybe in front in the midline in the symphysis region and we place the distractors and we activate them. So it kind of opens up the mandible and the maxilla, increasing the airway. And then these edentulous spaces, we can always rehabilitate it later. So this X-ray clearly depicts the activation of the distractor device. Genioglossal advancement. So imagine a patient who's got a properly placed maxilla, properly placed mandible, and whereas there is an issue with the musculature. So in that case, what we can normally do is we leave the base of the mandible untouched, the tooth-bearing segment untouched, and in between is where your genial tubercles are there. So we cut through and through, we pull it in front, and then we secure it. So that way you can see the opening up of the airway. So you can see it's kind of the tongue is protruding, blocking the airway, whereas here there is a slight opening up of the airway, as you can see over here. So moving on to hyoid myotomy. So basically your name itself says, so the infrahyoid group of muscles are kind of stripped and the hyoid bone is pulled anteriorly. So when the hyoid is pulled anteriorly, it opens up the posterior pharyngeal space. So there is opening up of the airway. Mandibular advancement, and because sole mandibular advancement. So sometimes there are patients with something called as retrognathia, so where the jaws kind of placed backwards. So in those cases, we just advance the mandible in front. So when we pull the mandible in front, so automatically the tongue follows. So there is opening up of the airway. So sole mandibular advancement, there are n number of studies to prove that. Just proves 3D volumetric changes in airway. And the biggest advantage of all these bony procedures is that the relapse rate is bit lower compared to the soft tissue procedures. So again, mandibular advancement up to 15 mm can be done by this procedure called bilateral sagittal split osteotomy. So wherein we place two cuts sagittally on the mandible and we advance it. So anything more than 15 mm, we can't really get it that much of advancement. So in those cases, we need distraction osteogenesis, wherein we just gradually increase it. So, or the term osteogenesis is, replaced by the term histiogenesis, wherein there is growth of the muscles and the vessels and the nerves as well. So yes, a patient with temporomandibular joint ankylosis, there is a very prominent retrognathia or reduced growth of the mandible. So in that case, there is a recent protocol given by Professor Neelam Andrede. So she says, first you need to go ahead with distraction osteogenesis. So get the airway opened up first, and then you can go ahead with your second stage, which is the ankylosis release. So initially it used to be the other way around, where they do the ankylosis release first, followed by distraction osteogenesis to open up the airway. So first, again, like I said, bilateral mandibular distraction osteogenesis is done for the correction of obstructive sleep apnea, and then the release of the ankylotic mass. So the surgical protocol will be first placing the osteotomy cuts, placement of distractors at the angle, and after latency period of 5 days, so distraction will be initiated at a rate of 1 mm per day till how much ever we want. You want 20 mm per day. You want 20 mm growth overall, so you activate it for 20 days. So, and then post-distraction, we do polysomnographic studies and supplementary analysis for the assessment of obstructive sleep apnea. And then once the patient is stable and once the consolidation phase of distraction is over, then we go ahead and do the ankylotic mass release. Right. So this is one such case. As you can see, the marked improvement in the airway. You can notice this area, this dark space So you can see the airway over here, the collapsed one, and after distraction, you can see the opened up airway. Maxillomandibular advancement. So again, single jaw movements are said to be a bit increased incidence of relapse. So wherever possible, we do both the maxilla and the mandibular advancements commonly. So that is much more stable. So like I said, maxillomandibular advancement. So we move the maxilla and the mandible together anteriorly, so that opens up the airway. So what are the advantages? It has got a very good success rate of over 86%, and there is a mean decrease of the apnea-hypopnea index from 63.9 per hour to 9.5 per hour, and that is increase in the quality of life, reduced symptomatology and reduction in blood pressure, and complication rates of 1 to 3%, and there is literally no mortality. Right. So, and maxillomandibular advancement, how much can we advance? So, for maximum benefit, it should be at least 10 to 12 mm of mandibular advancement. And there is no association between the degree of mandibular advancement and surgical success. And the relapse rate, whenever the more the advancement, there is more incidence of relapse. So, yes, can we induce let's say, an instance of obstructive sleep apnea? Yes, we can. So, especially in patients who have got a forwardly placed jaws, the procedure that we normally do is we cut the jaws and we kind of set it back. So, whenever we set it back, there are instances when the patients have gone and to develop obstructive sleep apnea. So in that case, so there are patients who have developed that. So patients began to snore loudly because the mandible is pushed backwards. So there is tongue fallback, collapse of the airway, and there is going to be obstructive sleep apnea. So in that case, what we can do is we can do something called as a genioplasty. So we push the mandible back, we advance the chin in front. So both are happening. So in that cases, yes, that will provide some help. So yes, so this is kind of the algorithm for when osteotomies are indicated. When there is a failure of all these things, then we proceed into maxillomandibular osteotomies. That will be all. Thank you so much.
Yeah, yeah, yeah. Dr. Pearlcid. Yes, yes, that Dr. Pearlcid, that was a wonderful talk. Little complex for the non-operating kind of people. Though I am an interventionist, I find it little bit Greek and Latin. But we are going to ask you questions in the panel in any case. So thank you very much for your very kind and wonderfully delivered talk. And you were still very brief. So I think you have done a wonderful job. Thank you very much for
Thank you.
putting the surgical perspective in a very right way. Thank you very much.
Thank you.
I invite the second speaker, Dr. Gauri Shankar. He's from Nellore, and Krishna Gattupalli, I think, is the hospital he works with. So over to Dr. Gauri Shankar for his talk, and then we will open the panel discussion.
Hi, I'm Dr. Gauri Shankar Krishna speaking. And thank you for the Chest Council of India to give me this this wonderful opportunity to present. And Dr. Ashish Dubey and Ashish Anil Maske and Dr. Chennai Vijay Kumarji. So thank you for giving me for this good opportunity. My concept is basic concepts of dental sleep medicine. So as you know that the majority of the factors are related to dental aspects during this obstructive sleep apnea. So I'm Dr. Gauri. It's my brief introduction. I'm Dr. Gauri Shankar Krishna, dentist and specialist in dental sleep medicine. And I'm dedicating my speech to Almighty, my parents, world's first lady dentist from the prehistoric India, Colonel Dr. Balkishan, Dr. Brain Palmer, and all those people who are suffering from OSA. So I'm thanking all the panels. So, while going to the factors means what is the importance of dental sleep medicine? The importance of dental sleep medicine is majority of the factors which regulate the obstructive sleep apnea are related to dental. Majority of them are related to oral cavity. That is, in another handle, they are related to dentistry. So that is the concept here. So the factors which are governing the dental role in the sleep apnea are large neck size, maxillary insufficiency, retroplaced mandible, mandibular micronathia, and macroglossia, oropharyngeal overcrowding, insufficient inferiorly placed hyoid bone, height of the hard palate, overcrowding of the teeth, class 2 and class 3 malocclusions, polydontia, oligodontia, and anodontia. These are the factors. And one more additional factor here is this particular narrow wall of posterior nasal aperture. So these are the factors which govern the obstructive sleep apnea related to the dental aspect. So here, how to correct them, that is the main concept here. So while the concept here is, while going to our previous slide, all these factors do restrict the tongue during the sleep time, so that the patient may get the obstructive sleep apnea. So these are the factors here. So now I'm going to present all the factors which are means I'm going to give you the brief introduction in the treatment modalities. As you know that all these factors are related to the dental aspect, and how to correct them. So directly I'm switching into that topic only. Okay, so because you are all the people who know about all the other factors. So here, mainly three treatment modalities are there. One is the surgical, second one is non-surgical, and third one is food habit changes. So coming to the surgical aspect. So in the surgical aspect, these are the factors, that is tongue-based suspension surgery, keyhole glossectomy, partial glossectomy with anterior wedge dissection, leaf or osteotomy, sagittal split of the mandible, hyoid bone suspension surgery, genoglossal advancement surgery, and uvulopalato-pharyngoplasty. So coming to the tongue-based suspension surgery, here a silk will be placed, will be passed into the tongue base, and the silk will be tied, and this will be done at the hyoid level. So while doing this particular surgery, the tongue base will be suspended, so that the patient will be getting sufficient oxygenation and get the full amount of air into the lungs during the sleep time. And then next one is a keyhole glossectomy. So if this happens during the macroglossia, and in that macroglossia, the situation here is, if the macroglossia is in the lower degree, this surgery is advocated. So, and then next surgery is partial glossectomy with the anterior wedge dissection of the tongue. So in this, what we do, so we take anterior central wedge dissection, and the central part of the tongue will be removed at the anterior part, and both the areas will be approximated and sutured. After the wound healing, whatever the tongue which occupies in the posterior airway, that comes forward, then the person will be getting more air into the lungs, so that the person will be away from obstructive sleep apnea. And then maxillary and mandibular osteotomy. So here what happens is the maxillary osteotomy is called as leafwood osteotomy, and mandibular osteotomy is called as sagittal split of the mandible. These two surgeries are the first surgery is for those patients who are having maxillary insufficiency. So in the picture you can see that the total bony part of the mandible is getting the advanced forwardly, and the second one is maxilla. So the second surgery is the mandibular sagittal split of the mandible, so that the mandible will be split posterior to the last molar, and the mandible part will be brought forward, and the plating will be done, so that when the mandibular maxilla are forwarded anteriorly, so the space of the tongue will be more provided, so that the patient will be getting sufficient oxygenation into the lungs during the sleep time. So this is the another advancement. So and the another surgery is the genoglossal advancement surgery. So during this genoglossal advancement surgery, what we do is we by engaging both the genoid tubercles, we do a rectangular marking, and the mandible will be and that marked place will be cut, and it will be brought forward, and 90 degrees tilt will be taken part, and that will be screwed to that will be screwed. So during this position, that whatever that genoglossal the advanced genoglossal muscle, this will be done for those people who are having more lengthier genoglossal, so that the genoglossal muscle, both the ends will be switched, so that the muscles will come forward, so that the posterior airway will be relieved. So, and another surgery is hyoid bone suspension surgery. This will be done for the inferiorly placed hyoid bone, to make the hyoid bone be relieved during the surgery. So that all the muscles which are related to the tongue, which are connected to the hyoid bone, will be corrected. So that is the thing. So, and another thing is non-surgical. In non-surgical oral appliance surgery, the therapy is there. In oral appliance therapy, mandibular advancement devices, tongue retracting devices, soft palate lifters, and mixed appliances, and OPAP are the treatment modalities. So, coming to the mandibular advancement surgery, mandibular advancement devices. So these mandibular advancement devices do advance the mandible during the sleep time. So they bring mandible forwarded, so that the forwarded mandible, when the mandible gets be forwarded, then there will be a sufficient aeration into the lungs during the sleep time. Here, the thing is, the total required advancement should not exceed more than 20 millimeters. That is the main concept here. So in that situation, the mandibular advancement will take part, so that the person will be getting sufficient oxygenation into the lungs, so that the person will be having sufficient good amount of sleep during the night time. And another thing is tongue retracting devices. So these tongue retracting devices do relieve the posterior airway by advancing the tongue mass into the bulb which is present in the appliance, so that this will be advocated in the milder degree of macroglossia. So in this situation, in the macroglossia, the tongue will be engaged into the bulb, so that the posterior airway will be relieved, and the patient will be getting sufficient oxygenation in the lungs. And next one is soft palate lifter. So in the soft palate lifter, the soft palate will be lifted by the lifting mechanism which is present in the oral appliance, so that the patient will be having posterior airway be relieved in the case of elongated soft palate, or and more sloped soft palate. In these two conditions, this will be used. So this is the advancement of this particular. This is the advantage of this particular device. And the next one is OPAP, means the combination of oral appliance with the CPAP is called as OPAP. So here two components are there. Means one is advancement component, and another is this CPAP component. Both the components do work simultaneously. This is advocated in the severe degree of obstructive sleep apnea. And coming to the food habit changes. So in the food habit changes, in the food habit changes. One is replacing the souring agents with the Garcinia gammigata and replacing the milk with donkey milk. So this Garcinia gammigata is having hydroxycitric acid in its component. So this hydroxycitric acid leaches out of the fat from the body, so that this particular food item, it helps in the maintenance of the body and in the milder degree of obesity. And the next one is replacing the milk with donkey milk, and this donkey milk will have the highest degree of protein content and lowest degree of fat content, so that this will also be helpful for the maintenance of the means away to be away from the fatty body. And here another thing is sleep pattern breaking techniques are there in the dental sleep medicine. So when the person is having sleep in the supine position, that also one of the contributory factors. So for that, this tennis ball t-shirt or packers, the snow relief cushions are in the use to give the changes in the sleep pattern changes. And in the preventive aspect, for the infants, instead of using the conventional bottle nipples, to use the bottle nipple which is in the shape of the breast, so that there will be completely even development of the hard palate, and the hard palate height will not be increased in this case, and as well as the posterior nasal aperture will also be sufficiently widened, so that the patient will be having sufficient oxygenation in the lungs. So these are the concepts here. So thank you for giving this opportunity.
Yeah. Thank you very much, Dr. Gauri Shankar ji, for this wonderful talk that you gave. And I think we have had a very, it's like almost like white balls, very, very wide, and somewhere very, very well above our heads for pulmonologists. So I think we are going to now go back to our, what you say, average knowledge pulmonologists rather than the big high flying surgeons and the dental surgeons. And we will start from the scratch back again, and then gradually build it back, go towards those very, very wonderful things. But I don't know how many of them are practicable in our setting. So I think let me introduce the panel, and I'll start with my dear friend, Dr. Indranil Haldar from Calcutta. He needs no real introduction. I think everybody in CCI knows him extremely well. He is one of the wonderful pulmonologists. I know him from Calcutta, and he's going to be there as a resource person today for the childhood or pediatric obstructive sleep apnea. Second is Dr. S Jayaraman. He is a consultant pulmonologist from Apollo First Med Belroth and MGM Hospitals. He's from Chennai. Welcome, Dr. Jayaraman, sir. Very glad to have you. The third, of course, is Dr. Kewal Dung. And Dr. Kewal Krishnan Dung is a consultant pulmonologist in private sector in Kota, and he's practicing sleep medicine since 2006. So he's long years behind him on the sleep medicine. And last but not the least, we have a young brain here, which is Dr. Abhishek Tandon. He's DM Pulmonary Medicine from AIMS Jodhpur, and presently he's pursuing his DM SRship in AIMS Jodhpur. So I think we have a mix of East, West, South, everything, and young and old, and very, very ancient like me. So I think, so with that, let us start this ball rolling. And let me see whether I can share my presentation in the first place. So does the admin have my presentation? If you can share it. Okay. I'll just see. Is this visible now?
Yes, sir.
Yeah, I'll make it full screen. Okay. So that's takes us to the panel discussion. I am going to start with rock bottom. Let's assume that, and this is the rock bottom of the whole story of sleep apnea, because everybody with a suspected obstructive sleep apnea who has high risk factors for having a significant OSA undergoes what is called as either a polysomnography, which may be the level 1 study, or a home-based study, which may be the level 3 study. And then you are thrown with the magic number of what is called as AHI apnea hypopnea index. Some people would prefer to use RDI or respiratory distress index. And if I have, for example, a very low AHI, this is nearly almost normal, but he has more than 10 RDI plus excessive daytime somnolence. If that is there, that means he has a lot of RARAs and respiratory effort related arousals, then he is still a candidate for a positive airway pressure therapy. Between 6 and 14, if there is either there are symptoms or there is sequelae. For example, somebody has got a premature brain bleed or something of that sort, or early hypertension, accelerated hypertension requiring more than 2 or 3 drugs. That is the sequelae and the symptoms of excessive daytime somnolence. If that is there, again he qualifies for positive airway pressure therapy. And if the AHI is more than 15, for all practical purposes, everybody qualifies for what is called as PAP therapy. But PAP therapy, though it is the so-called gold standard, and pulmonologists would love to just have one consultation with the patient and then a 3 monthly follow-up for all the life, and just to look at the AHI maybe on the mobile phones, because the auto CPAP machines are so smart today that they just give you the data. Even looking at the data alone is good enough. But that is not what happens in real life. Real life is much weirder. In India, you have a whole spectrum of people in the first place. You have people who are willing to undergo PAP but don't afford it also. And there are people who are sort of, just not willing despite being very affording. So I'm going to start with a very brief story, and then I'll invite the questions as we will roll on the questions. This is the story of a 35-year-old gentleman who was a smoker, and who definitely was a big snorer, big time snorer. And he came to us and we sort of did his sleep study. At that time, we were doing level 3 sleep study. Most of the times now we are doing, after COVID, we have gone back to the level 3 sleep studies, but we have access to a level 1 sleep study also. So we do not routinely do that because home-based studies are good enough in most of the patients. But occasionally we do move on to, when we have a complex sleep apnea or something like that, to a level 1 sleep study. Most of it are still are home-based studies. And he underwent two studies. One was a level 1, one was a level 3. Both showed an AHI of 85. Now, we counseled. In fact, I started giving him free counseling sessions after some time because he was not willing. He bought the machine and still wouldn't use it. He purchased the machine and still wouldn't use it. So he went to the best ENT surgeon in my city, and then he underwent a uvuloparatopharyngoplasty. He had a very stormy postoperative course. It was not easy at all because his HI was not very looked after. The anesthetists were not completely trained to look after that kind of they were not, and he's a CPAP non-tolerant. So what happened at the end of the day was he went into a pulmonary edema, somehow recovered. After 15 days, he's back with me again. And then we said, okay, fine. So you have undergone a surgery. So let us look at the HI again. And we looked at the HI, it had come down to 76 from 85. So we are still in a bad zone. And then another 6 months we spent on him. So total about year and a half that we spent on him. After a year of convincing, having the machine at home, not using a CPAP despite the best advice, trying to undergo everything that was possible. At that time, the mandibular advancing devices or tongue retaining devices were not there, and he did not have that kind of macroglossia to really think of that. But at that time, we were not so very well using the devices as today we are using the dental references very commonly done in people who are at least non-tolerators. But we were not doing that. And 6 months down the line, I get a phone call from he was from Ahmednagar, which was a nearby city. And his cardiologist called me saying that he is in acute MI, had an arrest at home, and he died. And this is the consequence or a sequelae of an untreated obstructive sleep apnea and a CPAP non-tolerance. So at that time, I really did not have an answer absolutely at all. And the first question, of course, to everybody is, I think largely, are we in agreement with this algorithm, or do you use different cutoffs? So, Dr. Jayaraman, can we start with you? And I mean,
Yes.
this particular algorithm which I discussed.
Good evening. Thank you, CCI, for this opportunity. So, Nitin sir, coming to your question. The question is, do you agree with this algorithm or you use a different cuts off? I fully agree. This algorithm is more correct. Only thing is, before PAP therapy, usually now this treatment modality is different nowadays. There is a multimodality treatment. Once you have patient has a severe obstructive sleep apnea by AHI or RDI, whether level 1 or level 3. So to start with, whether PAP therapy is a gold standard previously, nowadays there is a multiple treatment are available. Whether this patient is fit enough to undergo PAP therapy or not, we have to assess the upper airway. This is the tolerability issue. Patient can't tolerate. The patient purchased the machine, so not able to use the machine, underwent surgery and all. This algorithm is fit, except the directly go for PAP therapy is slightly, I am different in that opinion that. So once as a pulmonologist perspective, we do the sleep study, assess everything, AHA, RDA and all. Before the prescription of a PAP therapy, we have to assess the upper airway, whether tolerability, which kind of any severe DNS, difficult nasal septum or hypertrophic turbinates or upper airway narrowing by doing endoscopy.
Very good point.
Very important. But this 80%, I fully agree. This is okay. But before PAP treatment, upper airway examination by the ENT surgeon is very important in our practice. Yes, sir.
Yeah, Dr. Kewal, sir, very experienced person. So more or less in agreement with this one. Yeah.
Generally, I follow this algorithm, but in first case, where RDI is more than 10 and it has than 5.
Yeah.
Generally, patient don't accept CPAP, or at that time you can advise them positional therapy, such as maybe there may be
yes,
some.
Absolutely.
Otherwise, we follow all this algorithm.
Perfect. And I'll move on to the next $1 million question, and I'm going to quote some of the drugs which are being used. Of course, I think I don't have a problem with using modafinil in patients who are already on CPAP and they are still sleepy. So for that alertness part, modafinil is definitely recommended. But I have this question to both Abhishek as well as others. I'll mention a few drugs which have been mentioned here, and they are not exactly great drugs. None of them is approved by USFDA at this moment. One is our good old theophylline. Then there is a mention of acetazolamide. Then there's sulthiam, which is a carbonic anhydrase inhibitor. Then there is the drugs which are so-called reducing upper airway collapsibility, for example, desipramine. Then antimuscarinics, for example, oxybutynin. And then atomoxetine, it's a tongue twister, but I can't realistically take that name. And then there is one more drug, which is dronabinol, which is being tried. And there are some people, have been proposing something like medical cannabis also in people who are CPAP intolerant. And one of our colleagues uses a little bit of midazolam. So I think all this put together, what is your practice, strategy, or recommendation on any of these drugs and any other new experiences you have on using drugs in this? So Abhishek, we'll start with you first because you are fresh out of your DM program. So let's see, you must be pit-pat with the theory part of it at least.
At the onset, thank you so much, sir, and thank you, CCI, for giving me this opportunity to be a part of this panel discussion today. So as far as modafinil is concerned, like you very eloquently and brilliantly had put, that it's used to treat excessive daytime sleepiness in patients who are already using CPAP. Apart from that, all the other drugs that you've used and certain ones that are again there in literature like soramfitol or pitolisant, they are investigational, they are anecdotal reports, the case reports, there are certain case series, but none of them are FDA approved, none of them are being used routinely at any center across the country as per my knowledge. And so as far as the data is concerned, yes, it's there on theory, but I hardly doubt that any of the centers are using it or it has any proven efficacy, sir.
Yeah, I tend to agree with you on that. Indranil, any takes on any of the drugs, anything used? Anybody else also, Dr. Jayaraman, Dr.
Okay.
Kewal?
Thank you, Nitin. Just only one thing. So the modafinil is the one which we already have tried only in patients who have daytime symptoms even after using the CPAP or in
CPAP.
patients who are having narcolepsy. That's the thing. Other drugs are not in fact tried or we haven't tried it. But only thing which I'll tell you, we will always stick on convince the patient using the CPAP rather than moving on to those drugs. Again, these drugs are again maybe used for some other purpose or add-on maybe, but not as a sole agent, or even who are not tolerating CPAP. I will try to find out what is the reason for not tolerating CPAP rather than moving on to an alternative drug or something.
Excellent. Excellent. I think the point is extremely well taken. And if there are any inputs on this, on convincing or getting the patient back on CPAP, is there any trick that you do? How do you convince them? What is your methodology? All of you can comment on this, and then we'll move forward. Because this is a very, very important point that giving CPAP advice once is just not good enough. Like what we did for our patient, I started giving him free counseling sessions, completely free of charges, for nearly 1.5 years. It didn't work. That was a sad story. But then I think a good ENT evaluation in a young person is also very, very important. So the ear, nose, throat evaluation, possible surgical operability also to be evaluated if that is suitable.
Sir, in a case of a drug management for sleep apnea, mainly in a case of central sleep apnea, the chain stroke respiration as well as the cardiac failure stroke patients, we use this acetazolamide and adjuvant treatment along with the PAP treatment.
Yes.
And also we have a basic treatment for the severe cardiac failure like the diuretics and other medications with acetazolamide will help in improving the complaints and improving the daytime symptoms and other events. There are drugs plays a role in a central sleep apnea, but obstructive sleep apnea, despite using CPAP, patient is having residual daytime sleepiness. So modafinil is an add-on treatment, adjunct treatment. So we can start with 100 or 150 or 200 milligram once daily. This is the add-on treatment for this kind of residual sleepiness. Yes.
So Nitin, can I just chip in?
Yeah, yes, Nindranil.
So thing is that the more time we devote for counseling, that is the most important, as you rightly told. It is the counseling. And in fact, there are different studies which have shown that the more time we show them on counseling with repeated regular counseling. So about the techniques, about telling what the advantage that they will do with the CPAP. And we find there are important factors. One is the social. Just married people, letting them use CPAP will ultimately lead in divorce of them. Or another very important in this part of the world is financial. I have seen a lot of people, they're willing to buy. They know the advantage, but still the financial capability is not there and insurance company are not paying for them. That's another issue which we have to address because of the insurance company are not going with them. They're paying for these pacemakers, but not for CPAP. And the social problem that they are having. So one story that you told, the social problem, the mother will not allow the child to take the CPAP because they'll be dependent on that. So I tell them about this spectacle. You see, when you're using this spectacle, you will find it difficult for the first 7 days. But after you start using the spectacles, you see that you know how useful it is. So you can have it. Let us have a trial with CPAP. I give them a trial of CPAP, use them, see. And what important is that I make them talk with patients who are using CPAP. How they are tolerating it. Initially, they didn't tolerate, but now they are tolerating. So I let them have a counseling with other patients who are using CPAP.
Yes, I fully agree, Dr. Indranil's statement that counseling is very important, not only for the patient and patient attendants, wife and mother, father, children are important. And the finance factors are also very, very important. So we have to know the sleep study as well as the CPAP treatment also. We have to insist the policy makers and the insurance people comes under the cover of insurance coverage. This will improve the complaints of the patient. Apart from the good interfaces, counseling plays a major role. I fully agree, Indranil.
I think I have a short story to tell. One of my industrialist patients, his mother was convincing him for about a year. Every day she would phone him and say that this doctor has put you on a machine, he has ruined your life. So mothers also can be that kind of killers. Out of pure love for the child, she was almost ready to kill that child. And not the child. I mean, he is an industrialist, so he can afford anything in the world. And still, he was worried that he used to come to me repeatedly and ask me, are we really on the right path? Because my mother phones me every day and tells me you're ruined. I mean, I have ruined his life. So so I think that can go on and on indefinitely. That is always be there, will be there. The other technique, one of those tricks I use is and occasionally used. This was not exactly used for only CPAP patients. This is more relevant to the BiPAP patients. Those who require BiPAP. Some of them are very affording. They just buy the machine, but they don't have no know-how of how it applies, how it is done, and they're very reluctant and they give up using. So what I do is I do a short admission for that. Of course, this is a different ball game, but I occasionally do it for even a CPAP intolerant patients. I said, let us get you in for a while and let us do it under observation. We have a team of respiratory therapists and they educate, they talk to them, they convince them, they will talk to them about the therapy and they will document the oxygenation stability, the whole night pulse oximetry is redocumented again and shown to them. So even if they don't have a auto machine which cannot show them the data, you show them the data, and that sort of becomes a convincing tool. Plus the fact that under medical supervision, people behave themselves one way or the other. The fact that you are admitted is taken a little more seriously than a home usage. In fact, so many times people, are sort of so reluctant to have a person at home. So home-based studies sometimes fail because of that reason. And I move on to a level 1 study because the person is not taking the home, a CPAP trial also. So if he's not doing that, bring him to the hospital, and that might be one of the tricks I will suggest. Dr. Kewal, any inputs on from your side on this? Otherwise, we are moving forward. Dr. Kewal?
So you are muted.
Hello. Am I audible?
Yes,
sir, I am using Midazolam in severe emergency cases where patient is intolerant to NIV, especially. And it's too risky that time. It's too risky, but if you want to avoid intubation, then it's better way to give small sedation or in small doses, and patient will tolerate easily and you can manage easily.
Yeah, but this you would do it in the hospital setting under supervision.
In hospital setting. In hospital setting.
In a hospital setting, because at home it becomes too unpredictable. What dose, what they will do with that dose, and can be a little tricky. But I think it's an excellent observation that
one more thing.
Yes.
Regarding dental examination, there is some cases where patient have dental attrition, because of you can say approximation of upper joint causes the you can say some attrition occurs, and that causes the fall of the tongue, and that causes sleep apnea. If you treat that disorder, definitely there will be no need of any other therapy. Dental attrition.
That's right.
The dentist will tell you.
So a tongue retaining device is going to be useful. That one of
because of the decrease in the enamel of the teeth.
Okay.
Dental attrition.
Okay.
That also causes OSA.
I think we'll ask the dental surgeon. We have a dental surgeon, so I think he can answer this question. I mean, do we work on enamel?
Yes, sir. So that's something that we call as bruxism, or nighttime when you're sleeping, tooth grinding, basically on simpler terms.
They
so
grind,
grind the tooth so that enamel is kind of worn out. So if you notice, the height is lost. So I was having an interesting chat with Gauri Shankar sir. So he mentioned that this is more common in patients who are edentulous. So imagine we don't have tooth, then automatically the jaw collapses. So that kind of pushes the tongue backwards. So the same thing happens here. So normally let's assume we have a height of say 20 millimeters, and when there is enamel is worn out, so there is a reduction in that height. So automatically that kind of forces the mandible backwards and the tongue falls back. So that itself causes OSA. So once we restore that height, we can restore the patient's harmony.
Absolutely. I think very valid point, and very good that it was brought forward by Dr. Kewal and very well explained by you, Dr. Pearlcid. So thank you for that. I will move on now, and this is now again in the territory of surgeons and non-physicians. The guidelines for construction of either mandibular advancement devices, soft palate lifters, and tongue retracting or tongue retaining devices, and the significance of OPAP therapy in the treatment of OSA, especially in pregnancy. So Dr. Gauri Shankar and Dr. Pearlcid, can you come in on this?
Hi, sir. I am Gauri Shankar. So the guidelines of this mandibular advancement devices, total advancement should not exceed more than 20 millimeters.
Sorry to interrupt, Gauri Shankar ji, sorry to interrupt, but I think our question is more to do with moderate or severe, where CPAP is needed and CPAP is not getting used. In those kind of devices, what do you do with them?
Yeah, that's what I'm telling you. That's what I'm telling you. The thing is, the guidelines of construction of mandibular advancement device or soft palate lifter or tongue retracting device. In that aspect, the guidelines is, first of all, the bite recording should be very much perfect, and then total advancement should not exceed more than 20 millimeters. In this case, we can construct mandibular advancement devices. Then coming to the tongue retracting devices can be used in the macroglossia. So in that macroglossia, what we do is we create one bulb in the appliance, so that the patient has to suck the tongue, suck air from that bulb, so that the tongue goes and engages inside that bulb, so that the patient will be away from the sleep apnea. And soft palate lifters means when the soft palate is more sloped or it is more lengthier soft palate, in such situations we have to lift soft palate. So the guidelines is, it should not the lifting mechanism has to be taken part at the 50% of the total length of the soft palate. That is the thing. And tongue retracting devices is the bulb should be placed in between the bicuspids of the first bicuspids of the both the sides of the maxilla. That is the thumb rule. And the significance of OPAP in the treatment of OSA, especially in pregnancy. So significance of OPAP means oral appliance with positive air pressure. So this will be used in the severe degree of the CPAP, so that the air friction between the soft tissue of the oropharynx and as well as our laryngopharynx, and that will be reduced from for the maximum extent with the combination. And in the pregnancy, it is a very unfocused area in India. So when the fetus is size is getting increased, the lung volume goes on decreasing. So in such situation, the smaller lung cannot do the efficient oxygen transfer gaseous exchange for both the mother and fetus. So along with the positive airway pressure, a small amount of oxygen should also be incorporated along with the airflow, so that this oxygenation, extra oxygen, helps the patient to get more oxygen inside the blood, so that there will be a good development of the fetus. So that will be
prevented.
Yeah, so that is also not in the regular practice in India. That's what I focused.
Yeah, even in I the noticed guidelines, this is something which has been this is what the recommendations are. These are the factors reported for a better response with mandibular advancing splints. Younger people, females, as you said, pregnant females also could be included there. People with lower BMI, smaller neck circumference, relatively less severe OSA, a typically supine dependent OSA, healthy dentition with good protrusive range, a longer maxilla, a smaller oropharynx, smaller overjet, and shorter shaft palate. The last four, I really don't understand the relevance of them. So, Pearlcid as well as Dr. Gauri Shankar, please come in on this and help us on, how does all this work. The first 4 or 5 points I am understanding very well, no problem. Up to super independent OSA.
What's that? Super independent OSA means that's what I presented. Super independent means if the patient is having the sleep and back, so that is that causes of.
Then a positional therapy change also will be good enough in that situation. Yes.
For that, sleep relief cushions have to be used.
Absolutely. So the backpack kind of a technique or one of the techniques. But the last 4 parts of this, I need help from the surgeons. So Dr. Pearlcid, can you...
Smaller oropharynx, that is also told, and a smaller overjet means the overjet should not be smaller.
Meaning when we bite, sir, the maxillary tooth and the mandibular tooth, they just come in contact like this. So imagine when the overjet is very minimal. So that means that the jaw is not adequately placed. There is less space in the jaw. So that is what we mean by that. So when we have a smaller overjet, that means we have a posteriorly placed jaw. That is what we infer from that. So if we have that, then in that case, we need to advance it so that we create adequate space. So basically, I was talking a little bit about jaw expansion. So instead of expanding the jaw per se, we can just move the tooth a little bit, give some space for the tongue to be around so that we can increase the airway space. So that is pretty much the thing, sir. And again, long maxilla automatically means that is something that we call as a class 2 malocclusion. So meaning the mandible is back. So maxilla is forward. So that again causes posterior placement of the tongue, and that is a reduction of the airway. So all these cases, we can try and bring the jaw again. If you can notice this healthy dentition with a good protrusive range. So we need a good set of tooth to fix the appliances. So imagine if the tooth are all shaky, our appliance is not going to be stable. So we need a good set of tooth so that we can get the mandible in front. So for instance, this is what we are aiming at. So getting our lower jaw front, because that is the only mobile jaw. We can't get the maxilla forward. So this is the only thing that we can move. So maxilla we need to move, we have to do a surgery. So mandible with an appliance, we just try to get it forward, get some good space, and then give relief to the patient.
Yeah. So I'm going to go back to my physician colleagues and ask them how many of them are using regularly these mandibular advancing splints. What percentage of patients? So Dr. Kewal, can I start with you? I personally, I do send people, but they somehow don't land up using it because we are talking of CPAP non-compliant patients, and they are not great candidates for these oral mandibular advancing or oral appliances also, because that is another device which is going to stay inside.
None, sir. None.
So,
I have none. I have not.
Sometimes they say definitive surgery is more relevant. I haven't seen. Yes, Indranil, from your side, Abhishek from the AIMS. So
yes, Nitin. Only thing is that we do send our patients to the oral surgeons in that way. Those who have micrognathia, in fact, the ENT referrals also. So these are the patients whom we send. But ultimately, that's the thing. They don't go for surgical procedures. I think that it is again the fear in the mind of the patients that if they're not using CPAP, they are definitely not going to go for a surgical procedure.
True, sir. So here we have a data also, sir, cohort, like in our non-CPAP tolerant patients, when we send it to our ENT colleagues or our OMFS colleagues, we have observed that out of every 10 patients that we send in, approximately only 1 to 2 tend to convert. So approximately 8 to 9 would again not undergo the surgery or the procedure, and only 1 out of the 10 would do it, sir.
I think this is a very good insight, Abhishek, you have added.
Nitin sir, my take. Nitin sir, sorry.
Yeah, it is our practical experience also. Yes, sir. Yes, Dr. Jayaraman.
Yeah. My take in this surgery is, see, this kind of retrognathia, micrognathia, the mandibular advancement, osteotomy procedures and all, if do it correctly in a stage procedure, stage 1 or 2, whatever the our oral surgeon as well as the renal surgeon's opinion, so this is a curative thing. So in my point of view, mild to moderate cases requiring long-term, lifelong CPAP therapy. So in the case of very classical retrognathia, so we'll do the advancement oscillating procedure. This is a cure completely. This is a one-time curative surgery. So such a way that we have to counsel the patient if we want to have a lifelong treatment with CPAP, or is it any possible correction for such a kind of thing? That's why the treatment is a multimodality. That means once you diagnose, as a pulmonologist perspective, once you diagnose the sleep apnea, so what kind of treatment we are going to offer, whether PAP therapy or surgical treatment? What kind of surgical treatment? Are you going to do the ENT surgical fully, or is it massive advancement oscillating surgical procedure or oral appliances? So for that, we have to have the multidisciplinary team approach, like ILD and other discussion. We are going to have the other diseases. Likewise, we have to get on heterogeneous disease. One size does not fit for all. So the complaints rate, adherence rate of PAP therapy only 35 to 40% only. Remaining other patients, we have to treat the patients other modalities like surgical management, like oral appliances, oscillating procedures. A lot of surgical treatment by the ENT surgeons they are doing. This is all the procedures, 90% curative procedures. Curative, one-time surgery will cure completely. Otherwise, the meticulous choosing of patients is very, very important to go surgery. That is foremost important. So one question in the chat box, Dr. Anubhava from Coimbatore is asking me, once you diagnose sleep apnea, you counsel the patients about the ENT surgeon opinion and the oral surgeon opinion. Yes, if the patient condition warrants, definitely we send the patient to the oral surgeon, maxillofacial, to get the opinion from whether the patient will get a benefit or not. So this kind of approach we have to see as the broad range of view. This is my take on this.
Yes. But I think the word of caution here, that that so-called best surgery in the world, uvulopalatopharyngoplasty, the success rate of reduction of AHI is around 50%. It is not 100%. CPAP corrects it big time. It almost brings it down to less than 5 in majority, 90-95% of the patients who are tolerating CPAP. I agree that in a non-tolerant CPAP patient, I will use a surgical or a dental appliances or various other modalities. But if the person is requiring a CPAP in a severe obstructive sleep apnea, I am not really going to refer him to the surgery or force him through the surgery like what that man did himself. And then the end result was not good because the AHI, it does not get reduced beyond 50%. So it brings it down. And the other thing is the effect of a surgery is in an elderly particularly does not last very long. And the pain related to the surgery is about a month. So the cost, the pain of surgery, and all these factors have to be kept in mind. Agreed that we are really talking about this subgroup of patients who will go for surgery one way or the other because they are not at all using CPAP. So doing something is better than nothing, absolutely. But it should be done with a lot of caution, and this counseling is a must. Abhishek, you are raising your hand, so you have anything else to say?
Sir, you've
Abhishek?
covered my points, sir. You've covered my points. Sir.
Exactly. Yeah, yes, perfect. So I think we'll. This is another interesting take on this. So I'm just putting just kind of, this is not where we will recommend a bariatric surgery. The typical morbid obesity is say 120 kilos plus, 100 for women maybe and 120 for males, depending on their height, of course. And this is not a really morbidly obese patient, reasonably the average height of an Indian woman. And the AHI is 80 and she is not tolerating CPAP at all. So would you recommend a bariatric surgery in this kind of a scenario? Or if at all, I mean, this is a hypothetical question. So please think, where do you recommend a bariatric surgery? Do you lower your threshold for a bariatric surgery in a CPAP non-tolerant OSA who is obese?
Nitin sir, my question here is not tolerating CPAP. What is the cause of not tolerating CPAP? Whether it's the interface is not working properly.
Not tolerating simply means we have tried. No, we have tried and exhausted everything, the convincing, the experience, the documentation, even a free usage of 15 days, free counseling, everything is tried. And
bariatric surgery is indicated. Bariatric surgery is indicated here. It's indicated here.
Yeah. Because I'm not saying exactly in this situation, but whenever I have a patient who is obese, I will lower my threshold for a bariatric surgery from say 120 kilos to 100 or maybe even little lesser. In ladies, it might be even lower if there is a fat to lose. And the fat to lose will be a little bit of a fat lost in the pharyngeal space, and that might open up. So there is a realistic chance. So I'm not saying this is a algorithm for everybody. It will be for unique selected patients. You can't obviously do it for a 50 kilo per individual or a 60 or 70 kilo, 5 feet 10 inches tall guy. That is not going to work. But when there is obesity, when there is extra fat, and the pharyngeal space is also being compromised because of it, you might be using it in once in a while. Jayaraman sir, you were saying something. Sorry.
Yes. No, nothing. So, this is a patient very severe AHI of 80 per hour with the 80 kg woman, 150 centimeter tall. So this patient, no, despite the counseling, despite the good interface, the patient is not able to tolerate CPAP means we have to go for the other alternative methodology, whether any severe hypothyroidism to be ruled out first. And we advise to get an opinion from the bariatric surgeon whether feasible. As per the height and weight, this patient is obesity only. This is not a morbid obesity, it's obesity kind of thing. So definitely bariatric surgery help in reducing the AHI, and to control the other metabolic syndrome like diabetes, hypertension. Definitely there is a weight reduction will help in reducing the severity of sleep apnea as well as other metabolic syndrome. This is my take on this.
So Nitin, yes. Just to tell you that if you go by guidelines also, bariatric surgery is recommended if the BMI is more than 40, that is kg per meter square, or 40. In this OSA patient more than 35. So if the BMI is less than 35, it is better that you go by guidelines. Then we can tell that bariatric surgery may not help.
Tell that yes, by guidelines also.
Yes, let us go by guidelines. It is the BMI. Less than 35, absolutely. With OSA, bariatric surgery will definitely.
Sir, I think BMI is here around 35 and AHI is around 80 per hour. That is very severe. And bariatric surgery is recommended because CPAP is not tolerated by patient. And you don't have any option. MAD will not help much. It will not help. And sleep position therapy will not help in this patient because OSA is very significant and very severe here. That's why bariatric surgery is recommended here.
Yes, I fully agree with Kewal's statement. Nitin, one thing I contradict with your statement that all the guidelines are Western guidelines. Indian guidelines, the weight category is this patient comes under the morbid obesity, nearby morbid obesity only. So definitely she will benefit from the surgery. There is a bariatric weight reduction surgery. This is my opinion. Yeah.
No, Dr. Jayaraman, your point is well taken. First of all, we have to find out what is the cause of this obesity. Even if there is an endocrinological factor, if there is a hypothyroid, we have to correct that. That's the most important.
So before surgery, we have to thorough evaluation done by the endocrinologist, either hypothyroidism, either hormone imbalances. We have to correct with the medication. That is the first important thing. Yeah, after that only we are going to do the surgery. First, the correction is important. Or the correctable causes, we have to effectively correct. Then only we will plan for the surgical management. Yeah.
I have now these questions for both physicians as well as surgeons, but I think surgeons, we have more questions for them eventually. This is mainly for the directed at physicians. Is there any benefit derived from the so-called nasal appliances? You know, they sell you 5,000 or even 2,000 rupees worth on Amazon or whatever interfaces, which are so-called CPAPs. And I am not very sure whether they are commercially widely available. Some of my patients show me those devices also. I generally don't say yes to them, but at the same time, do you say yes to them in a CPAP naysayer? That's one. The second is, of course, we do try this BiPAP in certain situations where they are CPAP intolerant because the positive, the synchrony which happens with the positive pressure breathing in some patients is beneficial rather than harmful. In some patients, it is not so beneficial because they don't like extra air being flown in, whereas some patients like it. So it depends on, a borderline hypoventilating patient may benefit there. And the last person is auto servo ventilation. So do you resort to auto servo in your practice? I have had a few examples of auto servo ventilation working in select patients who were having a CPAP emergent sleep apnea, which was dominantly central. So that is in those kind of situations, auto servo was beneficial because it senses whether the person is going into a apneic spell or not, and a central apneic spell or not. So I think that so everybody, all
Nitin,
physicians.
The thing is that
yes,
a BiPAP is really indicated in patients who are having obesity, hypoventilation, who are having severe.
Agreed.
Yes, absolutely yes. And in terms of ASV, as we already do, is those patients with heart failure, central sleep apnea, ASV is very helpful. And your point is also taken. There is CPAP emergent, this obstructive sleep apnea.
Yeah.
Sleep apnea.
Sleep
as far as
sleep central apnea. Yes,
Central
yes,
apnea.
yes.
So, as far as data is concerned, the nasal appliances, there was a study published in JAMA, which categorically looked at non-CPAP compliant patients, and both the internal and the external nasal appliances were used. They were the dilators, and they had shown a 47% reduction in AHI compared to the patients who were using these nasal appliances against those who were not. So, but this was a one-off study. It was never replicated. So it shows a trend towards a benefit, and I think larger and more wide-based studies are required to answer this question. And as far as BiPAP is concerned,
sorry, I mean, I'll just endorse your point up to an extent, saying that look, nothing is being done, rather than that they putting those whatever small things inside, and whatever small benefit they are going to get, it may be worth it. But if at all, if it's a nasal block is the issue, then I'll rather have them go to the ENT, and if that is what is going to help them is a badly DNS or bad kind of DNS, that correcting that may have a better outcome, because he may eventually tolerate CPAP also better. Because sometimes for tolerating CPAP, you have to first do a nasal correction. So I think that their surgeons will agree that I think this approach might be better, rather than just giving them the so-called nasal CPAPs, where no pressure, no nothing. It works just because, and we are relying on him to keep his mouth shut.
Yes.
So that is that.
Abhishek, that study, the study that you are quoting is very important. In fact, it also decreased the oxygen desaturation index.
Yes.
So in that way, that study, though it was not, other studies were not done, but that study itself showed some of the response. Basically, it is a nasal dilator in that way. There are some internal nasal dilators also.
I think these studies are with the nasal expiratory positive airway pressure, not with the dilators. Dilators only improve
it was with the dilator, sir. This study is with the dilator. It's published in JAMA,
and they use only nostril dilator. It will improve the diameter of nostril.
Yes, sir.
It will not going to improve that pharyngeal collapsibility. It will not improve.
Palatal collapse is not taken care of one way or the other.
Definitely nasal register or nasal expiratory positive air pressure can improve.
Exactly. So the tolerance of CPAP will be better if a corrective surgery is done, because that is once and for all. Or you can use a device like OPAP, which Dr. Gouri Shankar was referring to. Is that right, Dr. Gouri Shankar?
Yeah, sir. Actually, here previously during your discussion, one of the persons asked about this nasal devices. So these nasal devices, if there is any block in the nose, they can't do anything. And second one is, if DNS, the deviated nasal septum is present, if the deviation is due to the cartilaginous part, oral appliance OSS O2, one oral appliance is there that helps for the maximum extent. So it pulls the labial frenum downwards. The pulling of the labial frenum downward stretches the cartilaginous part of the of nasal septum. If it is bony part, no nasal device works. That is my observation.
Alone will not. Yes. So OPAP is what we will recommend in this kind of a situation if he's not going to use any machine.
No. OPAP we had to use in the severe cases, not in the milder cases.
Not in the milder cases. Okay.
Actually, one of the panelists asked about the case that is intolerance with the CPAP. The main reason of the intolerance of the CPAP is the air blowing mechanism. In some patients, what happens? The air molecules do cause friction to the tissues of the pharyngeal region. So, because of this friction, what happens? The patient may feel that it is discomfort.
Yeah. So that creates a difficulty, and in those situations, you can prescribe OPAP and give it a
yeah, try. OPAP is the best one, because we are reducing the pressure of the pressure by relieving the pars maxima for the maximum extent.
And that in any case has nasal prongs, isn't it? I mean, so
No,
something
the nasal won't work. The nasal won't work.
Won't work. Okay.
The nasal won't work.
Yeah, Dr. Pulsit, do you have any other opinion on this, or we'll move ahead?
Which one, sir?
Dr. Pulsit, about this
nasal appliances. Nasal appliances.
Yeah, dental appliances do contribute for the maximum extent if it is mild to moderate.
Absolutely.
If it is mild to moderate, oral appliances do what? We have to evaluate the case. What is the cause of the obstruction we have to do, and we have to relieve that particular obstruction with the particular mechanism.
Perfect. So
like Kewal sir rightly said, so the nasal appliances, they don't do anything to the airway per se.
Correct.
So they just dilate the nostril, so that's nothing much that they can do, sir.
Yeah, I fully agree with that. Pearlcid, the main pathogenesis, the site of pathology is the retropalatal and retroglossal areas. Retropalatal, not in nasal areas. Any nasal block, if it's anatomically obstructing the thing, we have to do some corrective procedures before the PAP therapy. But the main procedure, main treatment is the open up the upper airway in the form of a retropalatal area, retroglossal area by the PAP therapy or surgical pharyngoplasty or the appliances like oral devices or MMA surgical and all. So the simple nasal dilator, it won't help much because the site of pathology in obstructive sleep apnea is the retropalatal and retroglossal area. That area mainly predominantly the soft tissue areas. There is no cartilage in that area. So narrowing, there are two ways. One is the dynamic obstruction, other one is the anatomic obstruction. In the case of anatomic obstruction, the surgery will help the pharyngoplasty procedures and all. If it's a dynamic collapse of the upper airway predominantly by doing the sleep endoscopy or the dynamic MRI, so the PAP therapy is a gold standard. This is my take on this kind of thing.
Sir, instead of going for dynamic MRI, MRI, simple lateral cephalometric analysis is much better.
It's also pretty good. Yes, agreed.
Yeah, simple lateral cephalometric analysis gives complete picture about posterior airway. And apart from this, one device is introduced in the market in the recent days, that is acoustic pharyngometric and rhinometry. That sends the ultrasonic vibrations into the up to the level of larynx. With the resonation means how bad such as food in the same mechanism, it gives the complete picture of the total airway mechanism. So with that device also we can get complete information. Acoustic pharyngometric and rhinometry.
Yes, that's why we involve the multidisciplinary treatment with ENT and dental and oromaxial, seeing the patients before prescribing the PAP therapy. These are all things are very important to maximum adherence of the PAP therapy or non-PAP treatment. Otherwise, they won't take any treatment at all. Already Dr. Nitin said one patient finally pulmonary edema and acute myocardial infarction died. We have seen a lot of patients like this. Some kind of treatment we have to give as a curative or controllable treatment. So this kind of attitude we have to develop in that patient kind of,
Absolutely. So I think now that brings us to something which most of us have not practiced or not done ourselves, which is hypoglossal nerve stimulation. If somebody has done that, please tell us that story. I will learn a lot from that. But this is what the guidelines at this point in time are talking about. If the person has a BMI of more than 40, AHI is between 50 to 100, so even a severe OSA is tackled by this. Age more than 18, it should be having less than 25% or central or mixed up. It must be a predominantly obstructive sleep apnea, and there should not be a complete concentric collapse of the palate. This our surgeons will explain once again. And this will be drug-induced endoscopy findings will show that no complete concentric collapse of the soft palate, and the person must be complete non-user of CPAP. So if that is the story, then hypoglossal nerve stimulation therapy is recommended. Now, more trials were done with BMI even less than 32. So the most United States commercial insurances require a BMI of only less than 32. So even a little less obese patients, they are giving it. In Europe, it is 35. In America, it is now 32. Though the starting recommendation was 40. So really morbidly obese patients will be requiring this. So I think that was the story. Anybody has any experience, any story, please share with us, because I personally don't have. But if you and Dr. Pearlcid or Dr. do you have a handle onto this? Because this is more or less surgeon domain. You're going to implant something into the hypoglossal nerve and stimulate it.
No, sir.
Like a pacemaker.
I have personally no experience on hypoglossal nerve stimulation therapy, sir. I'll be very frank about that. So yeah, I've come across that, but no, I have not seen one being done, or I have not done one.
Yeah, even I saw the pictures and I didn't really understand what were they doing. It sounded like a pacing of the nerve, and therefore the stimulation happening, and therefore a dilatation of the pharyngeal space happening. But I really couldn't understand how exactly was it done. Dr. Gauri Shankar, you have any inputs on this?
No, I too don't know about
this
hypoglossal nerve stimulation therapy, sir. I too don't know about this fact.
This seems to be coming up because we are talking of a very severe OSA also up to 100. It is being used, so it's not something. Of course, it will not be as good as CPAP possibly, but it will again at least give you 50% reduction in the HI, if not anything else.
But again, they have mentioned that no complete concentric collapse of velopharynx. So probably that's not a very severe case, if that's what they're trying to say. So maybe there will be a slight improvement in the airway, but not much. So if it's going to be a complete block of uvula, soft palate, lateral pharyngeal wall, and the posterior pharyngeal wall, complete collapse, in that case, I don't think it is going to be of any help. So probably a very mild case.
That is sort of a contraindication for it. So that is a contraindication for it.
Sir, what I understand, this therapy will act on genoglossus muscle, but because it will stimulate that genoglossus muscle and it improves the diameter of airway, but it will not increase the diameter of lateral pharyngeal wall. That's why it's not very effective in all cases.
Sir, if it is for genoglossal muscle, sir, if it is for...
sorry, I think one of you can go ahead, please. Dr. Gauri Shankar, first.
Yeah, if it is for genoglossal muscle advancement surgery is there.
No,
so that looks after everything for genoglossal.
But there is one option, it's there.
No, this is
another option is there.
Non-surgical sort of option.
It may stimulate hypoglossal nerve and it will contract the genoglossus muscle in phasic form. Yeah, pacing of nerve.
It's a pacing of the nerve, sort of. That's what I understand. Abhishek, you have any take on this? I mean, you are fresh out of AIIMS, and have you seen something like this being done in your territory?
No, sir. In our center, we have never seen a hypoglossal nerve stimulation therapy being done, sir. To be very frank about it.
Because I thought, the AIIMS may be the first place where this might happen. Of course, you are Jodhpur AIIMS, so it is not Delhi AIIMS, so possibly. But I think we can look forward to what I'm saying today is why we are reading it is possibly this may be applicable for some of our patients in future, not immediately, but maybe 5 years, 10 years down the line. But this may come. This is what is, because it is getting recommended and it is pretty good. The impact is pretty good. I think we have already touched upon this issue of, are there any tricks up your sleeve which can make CPAP patient, intolerant patient more compliant? I have already touched upon that. Posture and bed has already been talked. Yes, Indranil.
So anything about the humidification of the, does it help in your practice? Or when do you use a humidifier really?
Very frankly, Pune city humidity, it depends on geography rather than, say in a very dry place, the humidifiers have a positive impact. Pune city is more or less like Mumbai, very frankly. So it really doesn't. Mumbai or Pune, the humidity is so much that people don't really require to have an additional humidifier therapy. But if a person is experiencing dryness and because of the dryness he is discontinuing, then adding a humidifier does make a very logical sense. All dry cities, completely dry cities, definitely a humidifier will be recommended.
I can speak of Jodhpur, sir. Jodhpur being a comparatively very dry city, a lot of our patients have this problem where they say that they have experiencing a dryness of the mouth or the oropharynx, and humidification does help.
That's the thing. We have seen a few of our patients who tell that they have dryness of their mouth and dry air coming in. Humidifier might be of help.
Absolutely. So whenever the person utters the word dryness, I add a humidifier. Simple. Even in Pune, I do that. And it doesn't come at extra cost. Most of the times the cost is included or it is not very expensive either. So giving additional humidifier to a CPAP, in any case, there is an attachment. So you don't have to buy a very costly gadget. So it is easy to do that. So it will be one of those tricks which will work. Something on REM related OSA? Yes, Abhishek, you first go through that.
One more thing, sir, a lot of there are the subset of patients who also complain of leaks, and that is one of the major causes of them not being tolerant to CPAP. So changing the interface or tightening the mask helps.
So most of the time, what they use is either a bigger mask which doesn't fit in their face because it has been given by the company, the face mask. They do not
and they don't want to spend money on
absolutely
that.
Customization.
This is
most of the time
one of the
bigger
reasons
mask.
They are trying to be frugal, and therefore they are actually worsening their OSA because of the leak. And the leak becomes too much, sometimes goes into the eyes and things like that. So it becomes uncomfortable. Then they become CPAP intolerant. So I think very good point raised, that leak must be taken care of by a very proper. So with us, we have a team of respiratory therapists. So I make each and every of my patients spend at least 1 hour with my respiratory therapy team and do a proper mask fitting on that. Even if it is for a CPAP patient, we just call them to the hospital. Even if they are not admitted, they get a CPAP mask size sorted out, get a proper mask, and then they are on their way. So while prescribing CPAP only, we do this as a first step. So I think it will be a very important thing that will minimize the leaks. And they, in any case, once they come into the hospital, there is a machine available, so they can check whether there's a leak or not after applying all correct amount of pressure. It's not too tight, it's not too loose. All those things can be taken care of. Dr. Kewal, you have any inputs on this? And the next question also maybe for you, REM related OSA, because that doesn't seem to be throughout the night.
Nitin, sir?
Yeah.
Nitin, sir, regarding the does the sleep posture matters in the case of sleep apnea management? Yes, sir. There is a question in the chat box. Dr. Shivani, one of our CC leader, is asking about any role of polysomnography to ascertain if alternative therapies would help. Yes. In the case of polysomnography, level 1 or level 2 study, we can see the position associated OSA, POSA. In the case of position associated OSA, definitely there is a position treatment. Lateral decubitus posture is very helpful in relieving the obstructive airway diseases. By definition,
that's when the backpacks or things like that come in.
Yeah, in the case of AHI, we have to see the AHI in a supine AHI and a non-supine AHI. If it is the supine AHI is very high, double the values of a non-supine or very higher level, so we have to recommend the patient for the lateral decubitus posture lying down in that. So this is the POSA, that is a position associated OSA. From the PSG, polysomnography, we can diagnose the treatment aspect. One of the simple treatment is the position associated OSA with lateral decubitus posture. Yes, this is the one.
Yeah. Any experience on REM related OSA? I have seen about 2 or 3 patients who had dominant REM, pure REM, like almost no sleep apnea during the entire night, but REM only. And do you play any differently, or you use a CPAP? I have used a CPAP most of the time.
Yes, sir. Only thing is, in the case of a REM OSA, if you do the sleep study, level 1 or level 2, you can find out the REM sleep cycles once in 90 to 120 minutes. So predominantly, the patient have a false sleep in the later part of the night, mainly from the 2 p.m. to 5 a.m. and the 6 a.m. So in that case, the REM OSA patients needs a long term, that is a long hour of CPAP usages, mainly from 11 p.m. to 5 a.m. The 6 hours, the long duration of wearing the CPAP will help in relieving the OSA. Otherwise, the later part of the REM OSA, if you take the CPAP 4 a.m. itself, so it won't neutralize the late phase of a REM OSA. The REM OSA also we can define from the.
This is very important. The point that you are bringing out is very important, because many patients have this habit of taking a CPAP out at 4 a.m. or 5 a.m. and then going back to sleep again. And then if they have another REM and they are having a bad that way they suffer.
That's why the REM OSA patients needs a long hours of the CPAP. They have to wear the CPAP till morning 5 or 6 o'clock. Yeah, that's one we have to keep.
I've been doing the same, but I wanted to know if somebody else has some other ideas on this. Please.
So Nitin, by definition, you
now Indranil, you are the boss here. Your topic is all yours.
No, I'll go to that. But again, in order to call it a REM OSA, you have to have the ratio of REM versus NREM of 2 or more. And in that, these are also seen in pediatric populations also. And again, that has ultimate treatment is CPAP in that way.
Yeah.
So yes,
but if I'm not wrong, most of the benzodiazepines suppress REM, isn't it?
Yes.
Yeah. So has anybody played? I have not heard of this, very frankly, and I have not practiced it. But has somebody tried this along with maybe CPAP? Does it reduce it?
Sir, I want to
They
add
call it
something.
benzo buzz, because the previously level 1 studies used to show a benzo buzz, which is the typical the alteration in the REM happening because of benzodiazepines. So that was called as benzo buzz. So I personally don't have much experience on this, but if somebody is doing a lot of level 1 studies, he might be coming across people who are using on the sly benzodiazepines and along with this, and that might be one of the I wouldn't say contributing factors to betterment or worsening. I don't know. I don't have a very correct answer on this. Any other inputs from anybody on that? Now, otherwise, we move to the pediatric OSA, which is one of the last topics, I think, today.
Okay, Nitin.
So, this is
cup of tea that way. No. Just to give an highlight of pediatric OSA, I have been doing a lot of pediatric OSA. So first is that when you see snoring in children, say one important thing is that mother will complain snoring, or you have to ask them. You will see open breathing through their open mouth, failure to thrive again in some of the cases. Another is that school decreasing in school, say academic events. This is because of their daytime sleepiness, and they go on sleep during this school activity. So in these patients, you have to assess the adenoids and the tonsil, and a lateral X-ray of the neck for the soft tissue examination tells us about the adenoids and the tonsil, and you have to take the help of the ENT opinion also. So coming to your question, for absolute indication for adenotonsillectomy, first is adenotonsillectomy is the treatment of choice for pediatric OSA. That's the fact. But an absolute indication, if you tell, it is if there is an enlarged tonsil that causing upper airway obstruction or severe dysphagia or severe sleep disorders or any cardiopulmonary, say, complications, then it's an absolute indication. But in general, if you see a patient who is having pediatric OSA, the first choice is adenotonsillectomy. So what my take is, if you suspect an OSA in a pediatric patient, assess the adenoids and the tonsil, do a sleep study to see the AHI. If the AHI is high, go for an adenotonsillectomy. Repeat this sleep study, find it out, and after adenotonsillectomy, in many cases, the child may require a CPAP therapy. That's the caveat. So again, in pediatric sleep apnea, some of the tell the caveats. So failure to thrive may be one of the things that you may get in pediatric sleep apnea. In fact, snoring may not be present in many of the cases. Whereas in adult OSA, you are seeing obese and the patient is overweight. In pediatrics, this may not be the thing. Another is that if a mother tells that my child, when they go to sleep, moves on and rolls off and goes on to his back and moves from one end to the other end of the bed, you can suspect sleep apnea in those patients. These are some of the things which in our history, practically, we have to ask. And the best thing is to assess the adenoid and
particularly somebody who was doing reasonably well earlier stops doing well in the scholastic. That's another clue that, for no reason he is doing badly. Of course, I mean, movies and YouTube and so many other things are there which can ruin somebody's life. But if in the absence of any other contributing factors, if somebody is doing scholastically badly all of a sudden and is having that little bit of snoring, I think that might be another caveat which you can pick it up.
So though adenotonsillectomy is the treatment of choice, and again, even if the adenoids are not that huge or the tonsil are not that huge, pediatric patients who are having OSA, they do get benefit from even small adenoids or tonsil which are being operated.
Yeah, I fully agree that Indranil, pediatric OSA, the treatment of choice is no adenotonsillectomy, provided we have to rule out the other syndromic, no,
Absolutely.
associated syndromes we have to rule out. See, obesity, obese child with adenotonsillectomy, yes, of course, adenotonsillectomy will help, but simultaneously we have to repeat the sleep study and find out other syndrome associated. That patients definitely may require the PAP treatment and other modality of corrective procedures and all.
Absolutely.
Yeah.
There are some syndromic childs, the micrognathia, big tongue, and all those are there. And again, if you see some of the studies, there is a watchful expectancy. See, intranasal steroids with antihistaminics. There was a trial in which these patients were waiting for surgeries of adenotonsillectomy. They were given intranasal steroid. And ultimately, in many of the patients, the OSA component was decreased. So, watchful expectancy may be one of the modalities in which the parents don't want to go for an adenotonsillectomy, or is there is an absolute contraindication for adenotonsillectomy. There you can give intranasal steroids and then having an watchful expectancy to see whether the OSA decreases or not.
Absolutely.
And
I think,
one observation that I want to...
Just as we say CPAP, sorry, I'll just complete this. Just as we say there are CPAP intolerant patients, there are people who will simply refuse surgery, and
Absolutely.
you can't do much about it. It's a patient's will at the end of the day. So we can't realistically we can't force it down the throat of the patient. We have to somehow convince him, use all the convincing tools and get him on the line. So though it is recommended, sometimes it will not be done. So then other methods will come in one way or the other. Yes, whoever was speaking, please.
Yeah, I'm Sir Gauri Shankar. Sir, having the knowledge, having the dental knowledge in the knowledge, we can do wonders in pediatric sleep apnea, sir. So actually, the main thing happens is all the bottle feeders do possess obstructive sleep apnea because of that bottle conventional nipple, it increases the height of the hard palate. So increasing the height of the hard palate is one of the contributory factors for the obstructive sleep apnea. So that is one key that every person has to keep in the knowledge. And the second thing that I noticed in my practice is generally if the child is having the prolonged digit sucking, generally pediatric physicians do think that it is a normal milestone. But the prolongation of the digit sucking increases the height of the hard palate again. So in this situation also, the causes of having obstructive sleep apnea are much more predominant in such cases, along with which the mouth breathing and as well as tongue thrusting. These two habits also are the alarming things for a physician, that to notice that in the future days that particular child will develops obstructive sleep apnea. So having this adequate dental knowledge in the especially pediatric dentistry helps the dentist as well as the physician to make the child be away from the obstructive sleep apnea.
Absolutely. So I think before we go on to the last round, I'll make a few remarks. One of the very pleasant announcements I have to make is 982 people were awake at 8:41 p.m. 982 people were awake. I don't know for sure exactly now how many are awake, and those who are not awake, Krishna sir, CCI chief person, will be giving them free CPAP. So no problem. Their obstructive sleep apnea can be taken care of. But I think wonderful to have close to 1,000 people on such a vague and hot topic. So that is one very pleasant. Very nice, excellent. And hats off to CCI, hats off to Krishna sir for doing wonderful job. The sponsoring of CPAP was a joke, so please don't take it seriously. Otherwise, tomorrow there'll be a lot of messages on Krishna sir. So, okay. So I think I will request everybody to make the final remarks, and I'll make my final remarks in the end. I'll sum up everything. So we'll start with the youngest, Abhishek.
Thank you, sir. So I just have one point that we have moved from an era where we would give a CPAP upfront to all the OSA patients, and we've completely moved to an era where we would phenotype all the patients upfront. There are modalities like PALM where we use the pharyngeal critical closing pressure, the apnea threshold, the loop gain, and the muscle tone, and then we upfront advise the patient to go for non-CPAP devices where they would benefit from non-CPAP devices. So we should first of all not prescribe CPAP for all the devices. Second of all, the patients who actually need a CPAP, we have seen that the other non-CPAP devices don't actually help. So the mainstay of therapy in them is the CPAP. We should counsel them to use a CPAP. In case they are not using a CPAP, only in desperate measures should we restore to all these alternative therapies, in which again that we have seen that the data is lacking and we don't have a lot of options really to provide them. But phenotyping them and offering them upfront non-CPAP therapy in those in which it's actually indicated is actually very helpful.
Correct. I'll go to Pearlcid. I hope I'm right about the age estimation. I'm just looking at their hair and things like that. So I have the least of them, so I'm the last. So Pearlcid, you're concluding.
Yes, sir. So one is a thorough analysis, dental analysis per se, and like the cause of it, not just obesity. And again, like I think Abhishek sir rightly said, we can't force CPAP onto everyone. So we need to sort out, find out the reason for it. And most commonly, it is a dental issue. So it can be because of either a smaller jaw or a bigger tongue. So we need to sort out what the issue exactly is and then sort it out. And Indranil sir was saying about retrognathia in kids. So again, prevention is better than cure. So there are a lot of appliances which can modify the growth. So rather than thrusting surgery at the end of growth, we can just catch the child early, give them some appliances which can increase the size of the jaw and thereby prevent the child from developing OSA. So there are appliances like that. So I think it is definitely a multidisciplinary thing wherein all the specialists have to be involved in this.
Absolutely. Very, very nicely put. We'll move to Indranil. I think I hope I'm right again. I'm guessing the ages.
Maybe or may not be. Okay. Anyway, so yes. So being a pulmonologist on that side, I'm telling that, see, ultimately gold standard is CPAP. We all know. We'll try to convince the patient with CPAP, and the counseling and convincing is the most important. Definitely, there are patients who will be intolerant, and I will be going by Dr. Jayaraman's word. That is, we have to assess every patient from an ENT perspective. I was not sending from a dental perspective, but yes, now I think that yes, these patients are also to be followed up and also to be come back from the dental perspective also. So I have to send all of my patients to ENT. See, if they have a very deviated nasal septum to the highest extent, there is no use of using a nasal interface with a CPAP in that way. So ultimately, these are something which really we miss off. So some little tricks, by example, the leak as those cold humidifiers, all has to be taken care of. And ultimately, the social issues has also to be taken. The financial issues as concerns have also to be taken and addressed. And then we can really find out who the right candidates are, who may require an add-on or other than things that other than CPAP. So these may be other options, but there will be a few candidates whom we cannot convince, whom are desperate that they will not take CPAP, and we can go and move on to take those devices that are there or medications that are there.
Or the HNS may come in a few years and somebody will come with that training and that will start. Dr. Jayaraman?
Yes, sir. So my take-home message is very clear that one size does not fit for all. We are all practicing in an era of precision medicine. So we have to diagnose precisely. So what the category of disease? Already Abhishek told clearly, endotypes, phenotypes are very, very important. So meticulous history examination, pinpoint and confirm the diagnosis. So which kind of treatment we are going to offer based on the clinical and the imaging and the polysomnography, etc. Whether position treatment or CPAP treatment or surgical treatment. So treatment is a multimodality. We have to involve. We can lead the sleep medicine clinical lead, but there is a sleep medicine and sleep surgery. So pulmonologist, ENT surgeon, oral maxillofacial surgeon, dental surgeon, bariatric surgeon, endocrinologist. This is a combination of treatment. No, don't hesitate to get an opinion from the other department. So each department has, we are all complementary to each other. So we have to coordinate and do the best care for the patient. So one size does not fit all. This is a very important take-home message from. And the other thing is we have to do the sleep study and CPAP surgery and all. Insist the policymakers and government, insurance people to come under the coverage, insurance coverage. This is a very important thing from my side. Thank you.
Dr. Gauri Shankarji, because we need to have the surgeon, and then last will be Dr. Kewal, and then I'll conclude.
Yeah, yeah. The thing is, we had to concentrate on each and every aspect in detail to contribute in the field of the sleep medicine, and the treatment should be in such a way that the relief of the exact cause should be there. So that we can deliver a good treatment for the patient, and that's what I wanna tell you.
Thank you very much, sir. Dr. Kewal, sir, your last remarks.
Whatever option we have, but acceptance is very poor among the patients, and patient education and family involvement is very much important, and awareness among the clinician, primary clinician, is very important. That is to be taken care of.
I think these are absolutely golden words, that family support is the most important thing, because a CPAP is sometimes looked down upon. And the person actually, though he's breathing better, he stops snoring, he's looked down upon as if he's some kind of achut ke, and then sort of left alone, or you sleep away, that kind of a thing. He was snoring before, he was much worse, he was about to die, now he has a much better chance, but he becomes an achut because he's using a machine. And like I said, that the mother of the industrialist who kept calling him for a whole year, that your life is getting ruined by a machine. So I think the family support is a very, very important issue here, and getting them along in that team is going to be as important as all the other, the ENT, the dental surgeons, the maxillofacial surgeons, appliances, all kind of devices put together. Because today this topic that we took on is actually not a very easy topic, very frankly, very, very tough topic. I think all of you have put the ball out of the park, sixer, like we got South Africa out for 55. So so टेस्ट मैच में 55 बनाते हैं, वैसे यहाँ आपने छक्का मैदान से बाहर मार दिया है पक्का. So I'm very happy to have this panel and have this discussion. Such a difficult topic made reasonably simple, and lot of take-homes. The simplest things was like the bottle feeding, which Dr. Gauri Shankar brought. I didn't notice that. Very frankly, I have learned it for the first time. So I think there are those small things which have come from everybody. And thank you very much for contributing in such a very important symposium. I think this will go as a milestone in the CCI history. So not an easy topic. Once again, let me tell you, when I started reading, I said, मैंने कहाँ हाथ डाल दिया? But I think, overall, you have made it a success out of it. Both surgeons, Dr. Pearlcid and Dr. Gauri Shankar, thank you very much for being with us. I thank Dr. Abhishek, the youngest, then Indranil, then Dr. Jayaraman, and Dr. Kewal sir. I hope I'm guessing your ages rightly.
Wonderful moderation, sir. Nitin sir, wonderful moderation. You did an awesome job in the shooting questions and all. I enjoyed. I learned so many things from this platform. Thank you, CCI leaders. Krishna,
it was from the heart, from everybody. Though we used our brains, but it was definitely also from the heart. So thank you from the bottoms of my heart for being with us, and we'll conclude this session. Thank you very much.
Thank you very much. Thank you, CCI.
Good night. Thank you.